Hi, I'm Dr. Ramesh Ayala. I'm a full professor at Tulane University Medical Center in New Orleans. I also am the director for glaucoma services and the director for residency program at Tulane Ophthalmology.
My name is Peter Netland. I'm a glaucoma specialist and a professor at the University of Tennessee in Memphis. I do clinical work and also clinical research and have had experience with the Ahmed Glaucoma valve through those activities. The Ahmed Glaucoma valve has become a standard therapy for treatment of intractable glaucomas and is now used worldwide. The implant is now sold in over 80 countries on a regular basis and is used in virtually every corner of the globe. So it's now become its use is now international and it's become a standard treatment for difficult glaucomas.
What are some indications for use of the Ahmed Glaucoma valve?
The indications for the Ahmed Glaucoma valve include failure of other primary surgery, including trabeculectomy with mitomycin C, also scarred conjunctiva when there is inadequate conjunctiva to perform trabeculectomy, and then in addition, when the clinician feels that primary surgery with trabeculectomy is likely to fail.
What types of glaucoma do you think the valve should be used as a primary procedure?
There are specific glaucomas that we do use the implant for when treating patients primarily, in other words, using the implant for primary surgery. That would include neovascular glaucoma, when there's an advanced presentation of neovascular glaucoma, for instance, with a lot of inflammation and a closed angle. That would be a situation with a poor prognosis for trabeculectomy when a drainage implant such as the Ahmed Glaucoma valve would be likely more likely to provide success.
We also use the Ahmed valve as a primary procedure in all the following secondary glaucomas. Any neovascular glaucoma, any patient with penetrating keratoplasty and glaucoma, any patient with uveitic glaucoma, any patient with silicon oil related glaucoma, patients who had retinal detachment surgery with scleral buckle, ICE syndrome patients, and patients with traumatic glaucoma, and also acute glaucoma in patients with falling trauma with hyphema, 8-ball hyphema. Instead of draining the blood with the recurring hyphema formation, I tend to prefer putting in an Ahmed valve to control the pressure and drain the blood gradually.
What are some of the things that you do pre-op and post-op to make the valve surgery work?
All my patients before this, 3 days prior to the surgery, they have a pre-op antibiotic drop 4 times a day along with Acular or one of those anti-inflammatory medications. At the time of the operation, what I do is to use a combination of preservative-free lidocaine 1% mixed with 1 in 10,000 epinephrine, mixed 50-50%, 50-50 to dissect the subconjunctival tissue. I think this injection, subtenon's injection of lidocaine epi mixture, does 2 things for me. 1, it gives the anesthesia that is required, and 2, it does the dissection, and 3, it controls some of the bleeding that is associated with some of these eyes with a lot of inflammation, especially the neovascular glaucoma eyes. Post-operatively, I like to use 4 times a day antibiotic drop along with Acular and Cyclogel, and 8 times a day Pred Forte drops and Turbidex ointment at bedtime. You have to advise your patients to take a painkiller such as extrastrength Tylenol for the first night. After that, usually the operation is pain-free.
A couple of pointers about steps that clinicians can take to try to improve their success with preoperative and postoperative preparation. We do pay attention to the amount of inflammation, particularly in the postoperative period. Steroids are very useful and can be tapered according to the amount of inflammation in the eye. Sometimes in some situations with, for example, silicone oil in the eye or something else that may cause prolonged inflammation, it's important to keep the steroids going for a more prolonged period of time to allow the medication to help quiet the eye. We do use antibiotics in the early postoperative period, and then preoperatively, we don't treat preoperatively with steroids, although this, except when there are patients presenting with a lot of inflammation, and we don't discontinue the glaucoma drops until the day of surgery on a routine basis. We do, however, try to discontinue anticoagulants when possible. This would include particularly use of Coumadin and Plavix and other drugs like that, so that we can try to minimize the risk of bleeding complications during the early postoperative period.
What are some of the complications associated with valve implantation?
Complications can occur after the Ahmed Glaucoma valve. Fortunately, usually they're recognizable and treatable in most instances. There is potential for complications in the early postoperative period, and particularly complications related to hypotony. Fortunately, these are minimized by the use of the valved implant in the Ahmed Glaucoma valve, and we don't see those as commonly as we do with other types of implants. In the long term, after the Ahmed Glaucoma valve, there can be complications that can occur. We most commonly see an increased intraocular pressure.
The complications can be divided into immediate postoperative complications and late postoperative complications. Soon after the operation, one day after the operation, you can sometimes come across a flat anterior chamber, which could be because of one of three reasons. One, because of overfiltration, which is uncommon in the case of Ahmed valve because of the design of the valve. Two, and most commonly, it is because of the laxity of the lens. I tend to see this flat anterior chamber only in one situation in my practice, which is a phakic eye with a lax lens that moves forwards soon after the drainage of the aqueous from the anterior chamber. And lastly, it could be because of choroidal effusions, such as suprachoroidal hemorrhage, which is pushing the lens iris diaphragm forwards, causing the flat anterior chamber.
How do you overcome complications?
In a lot of these situations, conservative measures such as using mydriatic encyclopedic agents along with Pred Forte will resolve the issue in about a week to 2 weeks. Sometimes it may be necessary, especially if there is a lens cornea touch, it may be necessary for you to reform the anterior chamber with Helon.
If the tube is blocked or obstructed, then the clinician should identify the cause of the obstruction and treat the patient. For example, if the obstruction is due to fibrin or during the early postoperative period, intracameral tissue plasminogen activator may be very useful to dissolve the clot and restore flow to the implant. If the tube is blocked by iris or other tissue, then the clinician can treat the patient by mechanically freeing the obstruction from the tube, or by using a laser to unblock the tube. If the elevated intraocular pressure is due to a thickened capsule around the plate, then this can lead to a transient problem or a persistent problem. If the problem is transient, it usually starts at about 4 to 6 weeks postoperatively, and we refer to this as a hypertensive phase, but this elevation of intraocular pressure can persist. The way we usually approach these patients is by starting with glaucoma medications and digital massage, and trying to use conservative therapy to try to treat the patients. And if this conservative approach fails, and we still have an elevated intraocular pressure, and we feel that the pressure is too high for the disc, or the pressure elevation is persisting for too long, then we will go ahead and use other treatments to try to lower the intraocular pressure. The options at that point include excising a portion of the capsule around the plate and perhaps using 5-FU treatment to minimize rescarring. Another option is to use cyclodestructive procedure, specifically cyclophotocoagulation, and then finally we can even place an additional implant. Probably most commonly when we encounter this problem of a persistent elevation of the intraocular pressure that doesn't respond to medical therapy or digital massage, we probably most commonly at this point use cyclophotocoagulation to treat these patients.
A complication that I actually did not cover before is diplopia that is known to occur with any of these glaucoma drainage devices. The incidence of diplopia with Ahmed valves is approximately 4%, and that with the Barwalt is approximately 8 to 10%, depending upon the study that you see. The reason for the Barwalt to cause diplopia is because of the muscle entrapment, the operation is involved. Whereas with the Ahmed valve, the reason for the diplopia is the height of the bulb. And so before you insert implant the adult Ahmed valve, be careful to look at the size of the orbit and the way the eyeball is set in the orbit. If I have a patient who has deep set eyes and a small orbit, I tend to use the pediatric Ahmed valve in those patients, especially Oriental population where they have really tight eyeballs and narrow palpable fissures and smaller orbital space. If you put the adult valves, the likelihood of them to develop diplopia is very high. So I tend to use the pediatric Ahmed valve in these patients that will generate smaller, more flatter bulbs and avoid diplopia in this way. Should diplopia happen in a regular patient, what are the options that we have? You can needle the bulb to decrease the height of the bulb, which in turn should, along with aqueous suppressants, should decrease the height of the bulb and hopefully will resolve the diplopia. But if the patient has persistent vertical diplopia that cannot be corrected with prisms, I think in the interest of the patient, we have to sacrifice the surgery and choose to do some other kind of glaucoma surgery to resolve this issue of diplopia. And the surgical technique is pretty easy. You dissect the conjunctiva along the base of the bulb, reflect the conjunctiva posteriorly, cut into the bulb, and dissect the roof of the bulb, and take the plate of the Ahmed valve out and close the conjunctiva. Usually, this resolves the diplopia in majority of the patients. But like I said, the incidence of diplopia is not that high in my practice. Even if a patient complains of vertical diplopia within the first 1 week, don't do anything other than simple massage, because a lot of times this will correct itself. Take the drastic measure of taking the Ahmed valve out if the diplopia persists at the end of 2 to 3 months.
There have been comparisons of drainage implant surgery to trabeculectomy. It appears that in the short term, the efficacy may be comparable to trabeculectomy. One of the advantages of drainage implants is that in the long term, there would be less bleb-related complications in all likelihood because of the relatively high risk of having bleb-related complications that we see with trabeculectomy. Somehow the posterior blebs that are encapsulated and formed around the plate don't seem to be as susceptible to complications as the blebs that we see with trabeculectomy.
The tube versus trap study that came out of Bascom Palmer recently suggested that performing the tube surgery has additional advantages compared to the trabeculectomy operation. Trabeculectomy operation is, as everybody is aware of, is associated with a lot of potential complications, such as in the immediate postoperative period, unregulated overfiltration, giving rise to flat antechambers, choroidal effusions, suprachoroidal hemorrhage, a persistent hypotony that can result in cataract formation. And in the late period, the blood that is resulting from this trabeculectomy in this era of mitomycin usage can set the stage for leaky cystic blebs that need to be reoperated upon, and also can potentially cause endophthalmitis that can wipe the eye out. So in one sense, by avoiding the bleb at the limbus or in the perilimbal area, and moving the bleb away to approximately 8 to 10 millimeters away from the limbus by using these glaucoma drainage devices, you will avoid a lot of these bleb-related problems. It's almost unheard of for anybody to develop a cystic bleb that can get infected following any of the glaucoma drainage device implantations that are currently being performed. So, especially in a pseudophakic eye with open-angle glaucoma, I think if we crack the puzzle of fibrosis and hypertensive phase by developing a drug-coated stent glaucoma drainage device, I think there is a high likelihood that a lot of glaucoma surgeons would prefer the glaucoma drainage devices to trabeculectomy as a primary procedure in this group of patients.